Hi, sir. So my name's Dr. Morgenstern. That racing feeling in your chest, that's something that we call SVT. It just means that your heart is going too fast, and I'm going to have to get it slowed down for you. Now, all that silly stuff that we just did, getting you to blow in the syringe and then raising your legs way above your head, that does sometimes work. But at this point, it's time for us to move on and use a medication to slow your heart back down. Now, you're healthy, your blood pressure is fine, so we have a couple options that we could use. Option number one is a medication that works about 90% of the time, but it does cause a pretty horrible feeling when you're giving it. Some people describe it as chest pain. Other people describe it as a sensation that they are going to die. A lot of people have told me it's sort of the worst thing they've ever experienced in their life. Option number two is a medication that works closer to 100% of the time and doesn't cause any pain at all. Which would you prefer? So when I consider possible informed consent or shared decision-making conversations around adenosine, I am often surprised that it is ever used in the emergency department. Now, of course, that vignette is a little bit tongue-in-cheek, but the underlying truth is that we frequently give our patients a medication that does result in significant discomfort when there is an equally or potentially more effective medication that exists that has none of the side effects, and we don't even tell them about that option. I think if our patients were aware, they might revolt on us. So today we're going to talk a little bit about the management of what is usually referred to as SVT in North America. Technically, we should be calling it AVRT or AVNRT, atrioventricular reentry tachycardia. That terminology probably matters a little bit because even though we all understand each other in North America, the rest of the world does sometimes get confused by our terminology, and they are correct. SVT means supraventricular tachycardia, starting above the ventricle. So although it's true that AVRT and AVNRT are examples of SVT, they aren't the only examples. Atrial fibrillation, atrial flutter, multifocal atrial tachycardia, those are all SVTs as well. It's built into our culture. So excuse me if I say SVT a few times when I specifically mean AVRTs. That's just what we say in North America. All right. I don't know what I should do in the title. I probably still need to use SVT in the title so that people can actually find this video. Anyway, pedantics don't actually matter. Let's talk about management. And really, it's the medical management that I'm concerned about today. The vagal maneuvers are good, and obviously, yes, they should be tried first. After the REVERT trial, most people are using that modified Valsalva maneuver. My guess is that if you just did the whole thing with the person's tilted backwards with their legs up in the air, it would probably get the same results. I haven't had great success with the modified Valsalva. Either way, you're going to start with Valsalva. If the patient's unstable, obviously electrical cardioversion is the way to go, although that would be very rare and very odd. There's not much controversy about either of those points. What I want to talk about is the stable AVRT patient who doesn't convert with Valsalva maneuvers. Which medication do you use? And most people are taught, it's been built into the AHA guidelines for a long time, that the medication of choice is adenosine. But there is another class of medications that was widely used before adenosine hit the market. This was before my time. Calcium channel blockers are extremely safe and extremely effective. They were widely used before the very expensive new medication adenosine hit the market. And so, as often happens in medicine, the makers of the guidelines that happen to take a huge amount of money from drug companies all of a sudden decided that this brand new expensive medication was way better than this existing cheaper option. Let's look at some evidence here, right? Remember, adenosine was the new kid on the block. It was more expensive. It was new. So you have to ask yourself, does this evidence we have shift me away from what was standard of care, calcium channel blockers, to this brand new, more expensive medication? And we have a couple RCTs to look at. The first paper I ever encountered on this topic was an RCT by Lim in 2009. Right here, probably. 206 patients had SVT, again, AVRT. 104 were given adenosine. It was a 6 milligram IV push, followed by 12 if not successful, very standard. And 54 were given diltiazem at a 2.5 milligram a minute to a max of 50 milligrams. And 48 were given verapamil, 1 milligram per minute, max of 20 milligrams, all very standard doses. The calcium channel blockers were better than adenosine at converting patients back to sinus. It was 98% versus 87%, a big gap. Now, the calcium channel blockers did lower the blood pressure a little bit, but the changes were like 10 points, 10 millimeters of mercury, minor, likely clinically insignificant, and by 30 minutes, the blood pressures were all exactly the same. They do a cost comparison in this study, and the adenosine treatment is more expensive. So bottom line, adenosine is a clear loser. It's more expensive, has more side effects, and works less often. Nobody in their right mind would ever choose adenosine based on this study. Now, there were 8 RCTs done prior to this LIM study. They were summarized in a 2006 Cochrane review, and overall in that review, there's no difference in conversion rates, but there are more adverse events with adenosine, about 11% versus only 1% statistically significant. It wasn't statistically significant in the review, but I also noted that SVT recurred in 10% of patients with adenosine, but only 2% of patients with calcium channel blockers, which might make sense considering the timing, given their pharmacology. So I think the evidence-based medicine bottom line is really easy. Calcium channel blockers are at least as effective as adenosine, maybe more effective, cause fewer side effects, and are cheaper. So knowing that evidence, I really want you to picture an informed consent conversation for adenosine. What would that sound like, right? We have 2 options. One is more expensive, causes you more pain, and is probably less effective. Do you want that one? And yet adenosine is still given routinely around the world. I think probably without patient consent every single day. That just doesn't make any sense to me at all. Of course, evidence-based medicine always has caveats. And the most important caveat here is probably that the evidence doesn't really apply to sick patients. Patients were excluded from these studies if they had altered mental status, respiratory distress, hypotension. And calcium channel blockers are not an ideal first-line agent for patients in cardiogenic shock. Now, what's the best management option for a sick patient with SVT? I think electrical cardioversion is actually the best option, but look, a trial of adenosine might be reasonable if it's going to be quicker to administer than electricity. Of course, there's also an important role for clinical judgment when managing a patient with SVT. I'm not calling for an outright ban on adenosine. There are clearly patients who the risk of hypotension outweighs the short, brief pain and suffering. And occasionally we do have to perform painful procedures in emergency medicine. That's just emergency medicine. We shouldn't be discounting that suffering. But if you're using adenosine, I do want you to consider this. What do you normally do if you're performing a painful procedure? What would you do if you were going to electrically cardiovert this patient? Of course, you would manage the pain. We have procedural sedation for a reason. We use amnestic agents. But for some reason, emergency doctors routinely give adenosine, a drug that people say gives them the worst side effects they've ever had, without any sedation at all. I think because it's just short-lived, but that's cruel. And I think it has some long-lasting implications on our patients. Multiple times in my career, I've seen a patient with SVT who's been having symptoms for 2 or 3 days before they came to the emergency department. And I talked to them. I asked them why. And it's because they didn't want to get adenosine again. They didn't want to have that pain. So even though some patients will tell you it's no big deal, it is a big deal for other patients. It's not that hard. If you're going to use adenosine, and I don't know why in the vast majority of cases, but if you're going to use it, just manage the pain like we do in all of our other painful procedures. But I can count on one hand the number of times I've used adenosine in the last decade of practice. Essentially, always in a patient who's had it before, didn't have significant side effects, and said they wanted it again. Calcium channel blockers are just so much better. Not only are they cheaper and more effective and cause fewer side effects, but they're also way easier to use. None of this messing around with stopcocks or remixing the adenosine in a larger syringe for that crazy fast push. You just put a small dose in a mini bag, walk away and chart, and when you come back 10 minutes later, the patient is basically always in sinus rhythm and ready to go home. So if you're convinced by the evidence, by the argument, let's talk about a few practical points if you decide to start using calcium channel blockers for AVRT. I think the most important point is go low and go slow. AVRT, SVT requires much lower doses than you're used to. This is a very, very sensitive, arrhythmia. I think it needs much lower doses than even were in those studies. When I started doing this, I used the exact protocol from the Lim paper, which was 2.5 milligrams a minute to a max of 50 for diltiazem, and I never made it past like 10 milligrams, sometimes 15 milligrams before I saw a cardioversion. Once I started seeing that, it seemed like the 2-minute infusion was unnecessarily fast. So now I just take 15 milligrams of diltiazem in a standard patient or 10 in an elderly or small patient, put it in a mini bag, let it run in over 10 to 15 minutes, really slow. 15 milligrams over 15 minutes. Personally, I walk away. I let the nurse watch the blood pressure. I get some charting done. I see another patient if they happen to be really close by. And then 99.9% of the time, I come back in. The patient is in sinus rhythm, having zero side effects, zero symptoms, and they go home. In that 1% of the time where it doesn't work, I just repeat the dose. So instead of 15 milligrams of diltiazem, they get a total of 30. And so far, that hasn't failed me. And then the patient can go home. That's another topic altogether. These patients do not need blood work or really any other investigation in the emergency department. So within 20 minutes of meeting this patient, I have them ready to go home without any of that hoopla or extra staff or bed that the adenosine requires, and without causing the patient any pain at all. Now, of course, I'm prepared for hypotension. Hypotension seems more common in the literature, at least with verapamil, than it does with diltiazem. Although I haven't seen a direct head-to-head comparison, I tend to stick with diltiazem. If the patient does become hypotensive, most of the time, the best thing you can do is nothing at all. You just wait 3 minutes, repeat the pressure, and it will be fine. But in the very rare patient where you feel like you need to do something, a little bit of IV fluids basically always gets it done. And if you need to, you could give a little bit of IV calcium to counteract the calcium channel blocker. Now, although calcium channel blockers are not a great mix for patients with cardiomyopathy, the tiny dose here really sort of limits my concern, so I'm not overly concerned. And similarly, for patients who are already on beta blockers, we know we shouldn't mix calcium channel blockers and beta blockers, but the problems usually are at higher doses. And so if the patient took their beta blocker right before they came in, that might matter, but a low dose baseline bisoprolol last night probably doesn't matter that much, and I still use my low dose diltiazem. So that's my standard approach. I use it on everybody. I don't routinely perform an echo or anything else, but if the patient has been in SVT for a long time, and so tachycardia-induced cardiomyopathy is on the table, or if they have a complex heart history, then I'll slow down, I'll read the chart, I'll think about a bedside echo, and I'll think about my other options, which would include either electrical cardioversion or adenosine. But if I use adenosine, I will give the patient some form of sedation as well. This might seem like a minor issue, but I think it matters a lot. All on its own, the prevention of suffering seems like an important enough reason to avoid adenosine. Everyone always seems to argue with me when I say first do no harm is a silly saying, but then they turn around and push adenosine. Is that compatible with first do no harm when there's a more effective alternative that actually does no harm? But more than just preventing suffering, I think this is an important safety issue. As I said, I've had a number of patients over the years who sat in SVT for 2 or more days, not coming back to the emergency department because they were afraid to come in, because they knew we were going to give them adenosine. They'd been through that before and they didn't want to suffer again. When we forget about patient suffering, about our oaths, patients might choose to stay away from us, miss out on necessary care, and that is bad. So a plea, if you're not convinced by this evidence, if you still want to use adenosine, please treat it like you would any other painful condition. Provide your patients with adequate sedation. Although if your patient's sedated, I'm not sure why you'd use adenosine and not just an easier electrical cardioversion. All right, that's everything I have for this time. I know there are a lot of adenosine supporters out there, so leave your arguments, your comments, your dismay down in the comments. If you are enjoying these YouTube videos, I have started a YouTube membership program to help support the creation of this content. There are a few perks that might interest some of you, like early access to these videos, normally by a couple weeks, early access to a draft of the Broomdocs podcast so that you can submit questions and comments to us, and we might get them into the podcast before we record. And that's it. Until next time, take care.